Welcome to my case study. It's called Postoperative Renal Failure Related to Gastric Outlet Obstruction. My patient had a multitude of problems, one being something called gastric outlet obstruction, but then that led to renal failure. So I'll be walking you through the assessment and care plan. So during the presentation, I'll explain the patient's condition and I'll discuss the patient's status pre and post surgery, along with background information of the gastric outlet obstruction and postoperative renal failure. And I'll also discuss the application of the nutrition care process, which includes a DIME. My patient is an 81-year-old white female who's married and lives with her husband at an assisted nursing facility. And she has a daughter, and she lives close and provides her social support. And the patient quit smoking about 20 years ago and denies any alcohol use and illicit drug use. I was a little limited on the patient profile because the patient was sedated and pretty out of it. When she was awake, she's pretty lethargic, so she spent most of her time in the ICU, and I didn't get a good chance to talk to her or the family. However, I did get to talk to the nursing staff and the doctor a little bit, but really didn't get a whole picture. So this is pretty much the most I got on her profile for her social situation. So as you can see, she has a multitude of complications. I'd like to note in her past med history, she had duodenal obstruction and peptic ulcers in the past. There were other complications and conditions she has that I listed that I thought were important, but this is a limited list. There are many more. And she came in upon admission with constipation for the past 2 weeks, and her last bowel movement was actually 6 days prior to her visit. And she was nauseous and she was vomiting when she actually came in, but she had intermittent nausea and vomiting prior to visit as well. She has leukocytosis, she had a recent GI bleed, she complained of abdominal pain, which we were thinking was secondary to constipation, and she had an endoscopy which found multiple ulcers. And here's a list of her past surgical history. I noted the vagotomy for non-healing peptic ulcers. Basically, the surgery, what this entails is they take the vagus nerve and they cut it. I don't know if they cut it all the way, but they basically cut the branches of the vagus nerve that attaches to the stomach, so that way it slows gastric secretion and also helps prevent and treat peptic ulcer disease. Another thing I wanted to note was that she had a balloon aortic valvuloplasty and a valve replacement. This may not seem linked to her GI function, but in fact, it could be related to her kidney failure. So I wanted to note these. I thought it was pretty interesting, and I just wanted to list them so that you can keep these in mind throughout the presentation. So before I dive into depth with her diagnoses, I wanted just to give you the overall picture when she was admitted in the first few days of her stay at the hospital. So on the 16th, she was admitted with complaints of pain in her abdomen, bloating, nausea, vomiting, and these are symptoms of, or indicative of gastric outlet obstruction. On the 18th, she had an endoscopy, and this found her stomach was full of solid food, so a lot of it wasn't even digested. She had ulcers in the antrum and in the stricture between the first and second section of her duodenum. And they actually tried to dilate it to get it to kind of expand the duodenum, but there wasn't a benefit and it didn't really work. So then she went into, because this didn't work, on the 20th, they had a laparotomy and then she had a J2 placed. So she had a lot going on in the first couple days. On the 22nd, after these surgeries, there was many progressive problems, and this actually led to acute tubular necrosis, and this pretty much led to renal failure and metabolic acidosis. Next, I'm going to talk to you a little bit about the background of both gastric outlet obstruction and postoperative acute renal failure. Here's some background information about gastric outlet obstruction. It's also known as pyloric obstruction, and it's defined as a clinical and pathophysiological consequence of any disease process that produces a mechanical impediment to gastric emptying. And it's categorized into two different groups of causes, benign and malignant. And it's been shown that only 37% of patients with GU have benign disease. And peptic ulcer disease is actually the most prominent cause of this. And less than 5% of patients with peptic ulcer disease have GU. And of these, 5 to 8% undergo surgery, which is an estimated 2,000 cases per year, so not very common. And here's some major benign causes of gastric outlet obstruction. A few that I especially want to note, since these were a part of my patient's condition: peptic ulcer disease, gastric polyps, which she had, congenital duodenal webs, pyloric stenosis. I want to also note that ulcers within the pyloric channel and the first portion of the duodenum are usually responsible for outlet obstruction. In gastric outlet obstruction, patients will present with vomiting, and this is the cardinal symptom of GU. And early on, in early stages, patients will be vomiting, they'll feel nauseous, they'll have a lack of appetite, and this will happen intermittently. But as time goes on, these things will progress and get worse. And so until obstruction is complete, that's typically when this is a diagnosis, medically diagnosed. And this all leads to weight loss and malnutrition. So this is very serious and very hard to fix. Patients will continue to vomit, which leads to dehydration and therefore have electrolyte imbalances. And the stomach will be dilated so much that the stomach loses its contractibility. So gastric motility ceases, and it's a very serious condition. And all of this undigested food accumulates, which could also lead to aspiration pneumonia. So it's definitely a domino effect, and it can be very dangerous. Now I'm going to dive in a little bit about the postoperative acute renal failure. And the reason why I wanted to include this in my case study was because she initially was admitted without any kind of renal failure or any kind of kidney issues, but after her surgeries, her kidney function actually started to decline. And I thought that was pretty interesting, and I wanted to talk a little bit about that. So in my presentation, acute kidney injury and acute renal failure are used interchangeably. And this affects 1 in 5 people during hospital stays, and the condition is associated with considerably increased mortality. And with this comes along acute tubular necrosis, which leads to acute kidney injury or renal failure. And what acute tubular necrosis is it's the death of tubular epithelial cells that actually form the renal tubules of the kidneys. And so this is when there's a lack of blood flow and oxygen to the kidney tissues, and therefore it causes the death of these cells, and therefore leads to kidney failure. And so ATN accounts for 20 to 25% of all cases of hospital-acquired renal failure, which I thought was pretty interesting. And the incidence of renal failure, acute renal failure, is highest after major vascular, cardiac, and high-risk thoraco-abdominal surgery. And to add that renal dysfunction after surgery may result in a mortality of up to 60%. So there's a study that came out, a retrospective analysis of adult patients who underwent major non-vascular abdominal surgery, similar to what my patient had. And this study had 390 selected patients, 72 of which developed postoperative acute kidney injury or acute renal failure. And the median follow-up was 38 months, and there were adverse renal outcomes and death after hospital discharges and they were more frequent among these acute kidney injury patients. So I thought that was pretty interesting and applicable. And one last thing I wanted to note on this slide is the definition of acute renal failure. And this is defined as a rapid decline in renal function within 48 hours or so. And this results in accumulation of nitrogenous waste products, mainly of BUN and creatinine in the blood. So we've just defined what acute renal failure is, and now I want to discuss the types of acute renal failure. So there's 3 different types. There's pre-renal, intrarenal or intrinsic renal, and post-renal. Pre-renal is basically caused by decreased renal perfusion, often because of volume depletion. Intrinsic or intrarenal is caused by a process within the kidneys. There's a lack of perfusion causing acute tubular necrosis, which we had already gone over. And this is basically the cause of renal failure. And post-renal is caused by inadequate drainage of urine distal to the kidneys. An example is kidney stones. So an easy way to think about it is pre-renal is, since there's lack of perfusion, it happens before the kidneys. Intra or intrinsic is within, and post-renal, it happens after the kidney. And so when we think of kidney stones, it happens when there's an obstruction in the ureter or urethra, or perhaps even in the bladder neck. So think of it as after the kidney or post-renal. Now the percentages that you see at the top, pre-renal 35%, intra-renal 50%, and post-renal 10%, these are basically the cases in percentages. So 50% of acute kidney failures are intrarenal, for example. At the beginning of my presentation, I kind of breezed over her past cardiac surgeries that I wanted you to kind of think about throughout the presentation. So this is where I'm revisiting that. As we can recall, she had the aortic valvuloplasty and the valve replacement, and I think these were factors for her postoperative acute renal failure because of her current situation, her age, nutritional status, dehydration, and her past surgeries and procedures. Just taking all of that into account, along with these cardiac issues and her surgeries, this probably caused a decreased blood perfusion to the kidneys, therefore causing the cell death in the tubules of the kidneys, leading to renal failure. So this is just why I wanted to mention that, because it's interesting to see how everything connects. And prior to the surgery, I wanted to note she had 0 renal dysfunction symptoms, which I kind of mentioned before, but I wanted to reiterate that because it was really interesting that after the surgeries, everything just kind of declined. And I'm kind of attributing that to her cardiac health and her cardiac surgeries. So now that we have all the background information that we need, I'm going to run through the nutrition care process. First, in the NCP, we have assessment. As you can see, her BMI is 17.9, so she's underweight. She had an admission diagnosis of leukocytosis and a recent GI bleed. And per the MD, she didn't have any renal or urologic symptoms present. She came in complaining of vomiting, nausea, and no bowel movements. And like I mentioned at the beginning of the presentation, she's been constipated for a while, and her last bowel movement was 6 days prior to her visit. And she didn't really have any other symptoms that she complained about except for a dull abdomen pain that everybody was kind of attributing to constipation. And then she also had other findings include multiple ulcers in the interim consistent with peptic ulcer disease, which is another risk factor for developing gastric motility and emptying issues, and severely erosive esophagitis. This is a little bit more of a graphic slide, so I'm sorry if it's if you're a little sensitive to the photos, but I thought this was really interesting to see. I was looking at her chart, and they actually had photographs from her endoscopy, and so I found pictures to replace that because I couldn't extract the photos for the presentation. So this was as close as I could get, and it actually is pretty close. And the only one I'm missing is they had a picture of her stomach with the undigested solid food in her stomach, which is kind of interesting to see. Kind of gross, but interesting. So in square A, this is her duodenum, and you can see where the arrow is pointing. That is a polyp and the start of a peptic ulcer. In square B, kind of the same thing, but this is the gastric antrum. Same thing with C. There's multiple arrows there, one in the back that's kind of dark. This is the fundus. So this is a really painful, and the peptic ulcers and the polyps actually inhibit nerve function, which that in turn decreases gastric motility and secretion. So I just wanted to put that up there so you can kind of see what it looks like. It's pretty interesting. These are her labs. We were consulted on the 20th, and so that's when I started looking at her lab trends. This looks a lot worse than it is. Just on the left are the labs that I focused on, and then across the top are the different dates. And you can see on the 20th, her BUN and creatinine are pretty low. Her CO2 is within normal range. In the elderly, CO2 levels are between 23 and 30 milliequivalents per liter. And I looked at this range because it indicates the acidity status of the patient. And I also want to note that bicarb is an indirect measure of acid-base balance, so there's any kind of decrease in bicarb occurs with acidosis. And so this alone is a rough guide for the acid-base balance. We also see a decrease in the CO2 on the 21st through the 23rd. And it may mean that the kidney's function has decreased, as evidenced by the elevated BUN and creatinine levels as well. And this implies consistency with the low CO2, meaning the patient is in metabolic acidosis. So she had her surgeries, and so as you can see on the 23rd, I really want you to look at that date. This is where you kind of see everything go out of whack after her surgeries. So her CO2 level is very low, it dropped, and her BUN and creatinine just skyrocketed. With the decrease in CO2 and the increase in BUN and creatinine, we can assume that the patient is in metabolic acidosis. Further, I'd like to note on the 24th, the patient was placed on CRRT, or also known as continuous renal replacement therapy, so she was on a form of dialysis. And you can see that the creatinine levels are dropping and the BUN is normalizing, except for her sodium, which has actually gone up, but I'm thinking that had to do something with dehydration. Here's a list of her medications. This is an incomplete list. I didn't list every single one of them that she was on, just the ones that were related to her renal function and her GI. So basically the ones that were pertinent to this case study. And what was interesting, I thought, was that she's already going through a lot with her GI and decreased renal function as it is. And then you have these medications that only add to her issues. So it is a double-edged sword. These medications, she needs them, but some of them add those harmful side effects. So, just for example, you have the heparin, which is an anticoagulant that decreases her renal function. The meropenem is an antibiotic that increases her BUN and creatinine levels. So and then you have at the top there the bisacodyl. It's a laxative. It causes nausea and cramps. It's unfortunate. So it's just good to understand that a lot of what is going on in her lab work could be a result of her medications and or other physiological things going on in her body due to what she's going through, her gastric outlet obstruction. So it's just, I thought it was a good thing to see and lay everything out like this, so we can learn how to put puzzle pieces together. Another last thing that I would like to note on this slide is that the physicians were thinking about putting her on a medication. I think it was new. It's called neostigmine. It's at the bottom with the asterisk next to it. And the reason why I wanted to talk about this, even though she wasn't on it, they were really considering it. And my preceptor and I were talking about it. We weren't really sure why they were even considering, because it's a toxic and considered a dangerous drug. So luckily, they didn't put her on this medication. But the reason they were thinking about it was because it helps nerve impulses. And stimulating gas motility and nerve function of the gut. So they were assuming the nerves associated with the gut for motility. So, and I think that was even something that they were considering. But thinking about her medical past and her vagotomy that she recently had, they weren't really sure how well this drug would work for her anyway. And some of the common side effects and some allergic reactions, had she been allergic if they put her on it, include irregular heartbeat, seizures, vision changes, itching, difficulty breathing, difficulty speaking, dizziness, drowsiness, excess saliva, and the list goes on. So the risk definitely outweighed the benefit by far. So when you go into your rotations, it's really good to just look at the whole picture and definitely look at the medications and how it really can reflect in the lab work. So just a quick recap on her procedures. On the 18th, we remember she had her endoscopy, which found her stomach full of solid food and multiple ulcers. On the 20th, that's when she had her exploratory laparotomy, and she had a gastrojejunostomy. She ended up actually pulling the NG tube out, and they didn't replace it, so then she had a jejunostomy and basically had a J tube put in place instead. And so after her operations, she was diagnosed with gastric outlet obstruction and adhesions intra-abdominally. And here's a brief recap on her postoperative status. So her renal function has been declining status post-laparotomy, and this is indicative of her creatinine levels increasing and her urine output decreasing, and she's considered hypotensive, so there's less blood perfusion to the kidneys. She also has progressive problems and metabolic acidosis. And here's just a rundown of her diet orders since her admission. She was admitted on the 16th and came in on a diabetic diet, 1,800 calorie. And then you can see how it was kind of on and off from clear liquid to NPO. And then we started her on enteral nutrition. And then on the 27th, she was put on a regular diet from being on comfort measures, which I will go into here in a minute. Here's her calorie and protein needs. We started her off low, and then we increased it over time, basically to prevent refeeding. So we started her off at 30 to 35 kcal per kilogram of her actual body weight, and then increased that to 35 to 40. And then we kind of did the same thing with our protein. We increased it as we increased the calories. And we started off with 1.2 to 1.5 grams per kilogram of actual body weight, but then we increased it to 1.5 to 2.0. And this seems a little high, but as we know, she had gone through the surgeries, she's malnourished, and we're just trying to prevent loss of lean body mass. Okay, next in the nutrition care process is diagnosis. And my PES statement for the diagnosis is inadequate energy intake related to altered GI function from gastric outlet obstruction, as evidenced by NPO status, BMI of 17.9, and progressive vomiting. Next in the NCP is interventions. So we made suggestions made for enteral feeding once medically appropriate, and we wanted to put her on Glucerna 1.2 at 62 mils per hour to provide the patient with 1786 kcals and 89 grams of protein to meet her needs. But until that point, we had to put her on TPN or PPN, and we worked with pharmacy on that. As you can see, on the first day, she was only provided 510 calories, 170 coming from her amino acids, and 340 coming from the dextrose. And this is basically to prevent overfeeding and refeeding syndrome, because that could be kind of dangerous. So throughout her stay, we monitored, we titrated up, and advanced her TPN administration. And we had a pretty good team approach. The nutrition team worked with nephrology, pharmacy, the surgeon, and MD. And nephrology was consulted to evaluate the renal insufficiencies since her labs were altered, which indicated possible renal failure. And the surgeons were consulted and brought into the discussion as the patient had been through her procedures in the past, and also to gather data from the endoscopy and her exploratory findings. PharmD, or pharmaceuticals, worked with nutrition to work out electrolyte imbalances for the TPN solution complex. So it truly was a team approach. Next to the NCP is monitor and evaluation. And every day the dietitians work with pharmacy to make sure her electrolytes were balanced, but also to make sure she was getting enough calories. So you can see on the 22nd, she was only getting 960, but on the 25th, she was meeting her needs at 1670. And this is basically just to prevent refeeding. This slide shows a little bit more specific detail on a few of the days remaining in the hospital. On the 24th, the patient was put on CRRT dialysis. Her TPN was up to goal. Her weight increased 20 pounds overnight, so that was from fluids, so they diuresed her. Like I mentioned before, she wasn't really ready to feed enterally yet. And on the 25th, her CRRT continued, and her weight had decreased, which is good. She actually started having some bowel sounds and activity, so the MD approved her to start feeding via GJ tube. But they were kind of thinking her prognosis was poor. And on the 26th, the patient was placed on comfort measured, and her TPN was discontinued. So even though her bowel was starting to make sounds, she could have started feeding. I'm not sure if the family wanted to just discontinue everything because of her age. She was 81, and there were so many issues, and she was having renal failure, but all of that probably could have improved over time. But it was up to the family, and so she was placed on comfort measured, and on the 28th, the patient passed away. One of my nutrition recommendations would have been introducing TPN a little earlier. The patient may have been malnourished, and she was underweight, and she had many nutrition-related issues, and so TPN really didn't start until midway through her stay. So I would have introduced that earlier before surgery, and it could have improved the patient's prognosis, but in reality, it's really hard to say. In summary, this case study demonstrates the complexity of finding a root cause for a condition, especially in renal failure. As we know, there's many factors that goes into her diagnoses, and especially in renal failure where medications can have adverse effects. So it's just really important to step back and look at the overall big picture. And during my presentation, I reviewed background information to understand gastric outlet obstruction and post-operative renal failure conditions. I reviewed the TPN and PPN for medical nutrition therapy, and I also reviewed the nutrition care process application and recommendations. I hope that you learned something and you're able to take some of this information with you while you explore the dietetics field.